Well, hello everyone. This is Dr. Pressprich, welcoming you to Michigan Institute of Urology's webinar series. This is one on kidney stones, and the title of the talk is Not a Stones Fan. And I'm sure many members of our audience tonight has probably experienced the joys of stones. But tonight I'm going to try to talk about some of the major causes, the treatments and steps to avoid ever getting a stone, and if you already have stones, how to get out of that mess. A little bit about me. I actually am a Michigan native. I grew up on the west side of Ann Arbor. My Bachelor of Science is from the University of Michigan. I then went to Wayne State University School of Medicine for both my medical school and my residency. My specialties and interests as a urologist currently are cancers, stones, BPH, and erectile dysfunction. And my offices are both on the west side of the metropolitan area, being Brownstown and Dearborn. And I do most of my operations actually at Corwell Dearborn, or the old Oakwood Hospital. So just real basically, what is a kidney stone and where do they form? Well, they come from the kidneys, and the kidneys are bean-shaped organs that sit kind of next to the spine or the back of the body, and their function is really just to filter blood, get rid of any extra water, salt, and waste, and put it out in your urine. But as part of that, they concentrate a lot of minerals together, and they can form stones. And when those minerals reach certain concentrations, they can crystallize, bind together, and form inside the kidney itself. When they first form, they're usually sitting in the kidney, and usually they're asymptomatic. And they can sit in the kidney and grow for years. However, they can also drop into the ureter, which is the tube that drains the kidney into the bladder. And at that point, oftentimes they can get stuck and cause problems, pain, obstruction, infection. And approximately 10% of our population will develop a stone at some point in their life. And so kind of looking at the anatomy here again, here are each of the kidneys, and the one on the right is sectioned to kind of show you various points where stones can hang out. Again, they start their life kind of inside the kidney where the urine is dropping into the collecting system here. But as they grow, they can also drop into the ureter and cause obstruction. And they can be quite large. The largest stones I've treated are probably in the range of 2 to 3 inches in size. But I've also seen stones on the order of 1/4 of an inch or less, drop into the ureter and cause a lot of symptoms. So it's not necessarily the size that's going to be an issue. However, the bigger they are, in general, the harder they are to treat. Stones are made up of various minerals, and we just classify them by the mineral they're made of. That's kind of the most straightforward way to do it. By far, the most common one that I see is calcium. It's usually calcium oxalate. Calcium and oxalate are 2 minerals that are naturally present in the body. However, if you have too much calcium, too much oxalate, and especially in concentrated urine and someone who's not drinking enough water consistently, that can certainly lead to their formation. Uric acid is also quite common. Purines are actually from the proteins in our diet, and particularly from animal proteins. They can also be more common in folks with gout, diabetes as well. Also, people who are obese will more commonly have uric acid stones. And again, organ meats, animal proteins, shellfish are all kind of high purine foods. So not necessarily something to avoid if you're not struggling already with this stone, but if you do have uric acid stones, things to look out for. Struvite stones can be difficult to treat. They're actually caused by infectious organisms. And unfortunately, the only way to cure that infection is to get rid of all of the stone, which can be challenging because those stones can be quite large. And then finally, I sincerely hope none of us in the room today have cystine stones, but these are a genetically caused stone, which can be quite hard to treat and to prevent, and also tends to run in families. So who gets a stone? Well, again, about 10% of the population will get a stone at some point in their life. And about half of those people will go on to have another stone. So in the room tonight, I suspect we have a lot of our habitual stone formers. Family history certainly plays a role. Genetics are certainly here. White race does make them somewhat more common. However, anybody of any ethnicity can have a stone. Again, people who don't drink enough fluids, chronically dehydrated, are the most likely folks to get a stone in the first place. People with high protein diets, people who are eating a lot of salt or sugars, those will also promote stone formation. Vitamin C supplements actually in high doses can actually form more oxalate in your urine and make you more likely to have an oxalate stone. If you had any kind of bowel or stomach surgery, particularly bariatric, that will make you more likely to have calcium oxalate stones. Diuretics, antacids, certain anti-seizure medications, certain anti-headache medications can also promote stone formation. And then finally, blood pressure, but especially diabetes and obesity are major risk factors for stone formation. So how do you know if you have a stone? Most people who have had a stone tell me this is the worst pain that they've had in their life, and that includes women who've had children, who've been through childbirth. They say that oftentimes it's worse than that. It doesn't necessarily have to be that extreme. It can kind of wax and wane, and it really just depends on how obstructed the kidney is. And the pain is in fact due to the kidney obstruction. So if the stone is just sitting up in the kidney, again, you probably won't have many symptoms. However, if it's blocking something, your kidneys will let you know about it. It does come and go in waves. It can be associated with nausea, vomiting. If it's close to the bladder, it can make it feel like you have to go to the bathroom a lot. It will come on suddenly, and all of a sudden, you'll feel like you have to go all the time, or you're burning with urination. And in some ways, can mimic a UTI. If you have a urinary tract infection on top of a stone, that can be a dangerous situation and can cause sepsis. So fever plus any of these symptoms can quickly become an emergency situation. And again, this slide is just to harp on the point that, even very small stones, if they're in the wrong place and causing obstruction, can still cause a lot of symptoms. I've seen stones as small as 3 millimeters, put someone in the emergency room and even need a multiple stay a day in the hospital just because of how much pain the person was in. So, how can we prevent stones? Well, the first thing I tell all of my patients is drink, 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 drink. Fluids are your number one defense against forming a kidney stone. And some fluids are better than others. Water is a great place to start. Some people think that coffee causes kidney stones, and actually the evidence shows that coffee is neither good nor bad for stones. Lemonade is actually good for stones because it's got citrate in it, and citrate is a stone inhibitor. So you got to make sure that you're not confusing that with vitamin C. Vitamin C in too much quantity can cause kidney stones, but citrate in the form of citrus fruit prevents stones. So citrate is good. Too much vitamin C is bad. Grapefruit juice. I'm actually going to disagree with this one. I think grapefruit juice actually helps prevent stones because it's got citrate in it. And then colas certainly can promote stones, as well as sugared beverages of other kinds. And this is probably true. Kidney stones in summer due to high heat, drinking less. Certainly in places that are hot all the time, like the Southwest, we'll see more stone formation in general. So, in terms of dietary choices you can make to reduce your stone risk, I don't necessarily tell all my patients to avoid all of these. Oftentimes I'll get specific testing to kind of figure out what their individual risk factors for stone formation are. And if, they were high in oxalate, for instance, and that's what they needed to avoid, then yes, they should avoid spinach, berries, chocolate, nuts, beets, tea, rhubarb. But often before that kind of testing, I don't have patients knock out a lot of this stuff right off the bat. Dietary calcium it's kind of a sweet spot in terms of stone formation. You want enough calcium to support good bone health. You also want enough calcium that you can bind a lot of the stone forming minerals in your gut before they get to your urine. So Actually, some calcium in your diet prevents stones, which is kind of counterintuitive. However, you can also overdo it. So usually the recommendation in this space is probably somewhere between 800 and 1,000 milligrams of calcium a day, which equates to a few servings of dairy, or like a tablet or two of a calcium supplement. And again, point 3 here is avoid the extra calcium supplements unless they're prescribed to you. And actually the same goes for vitamin D. There is certainly potential to overdo it, but you also want to get the right amount. Protein, particularly for uric acid stone formers, can be a stone promoter. So most folks with uric acid stones, I suggest would eat less than 6 ounces of animal protein a day. Interestingly, plant protein is still just fine. Salt intake will increase your urinary calcium. So particularly for patients with high calcium in their urine, I will have them reduce their salt intake to about less than 1,500 milligrams a day, which is good for most of us anyways, because it will also improve your blood pressure. And then again, number 6 here, like I said earlier, avoid high doses of vitamin C. So how do we treat a kidney stone? So a patient comes in with a lot of pain and we think it's due to a stone. Well, usually we get imaging to confirm that, but then we also can usually figure out how big the stone is. Smaller stones, and that's stones less than about 7 millimeters in size, will often pass on their own. At or above 7 millimeters in size, they become less and less likely to do that on their own. It can take some time, but we don't just leave you to suffer. We will often give you pain medications, medication to help the stone pass so that you can kind of do that comfortably. And many patients do very well on this and can avoid procedures, while their smaller stone does pass. So medications that we use to help stones pass, Flomax is very effective for stones, particularly that are kind of in the lower half of the ureter, and on the smaller size, less than 5 millimeters. And that is a medication that kind of relaxes the ureter and helps it open. Painkillers, probably the best, if you can take them in this situation, is probably Motrin or another NSAID. Narcotics can be effective, but maybe not as effective as Motrin. And then uric acid stones, it does say here that they can be dissolved with medication, and I would agree with that. But however, if someone has a uric acid stone sitting in their ureter, oftentimes they don't have time to wait for that to be dissolved. So oftentimes that one needs to be passed on its own or treated. But certainly uric acid stones in the kidney can be dissolved. Procedures. This is a very popular one in this space. Ureteroscopy is a mainstay of stone treatment. Unfortunately, it can treat pretty much most stones within the tract. It's generally a outpatient procedure, probably about less than an hour under general anesthesia. It can treat stones within the ureter or within the kidney itself. Stones can be directly grabbed and removed, and that's what this schematic is showing you here, if they're small enough. If it's a larger stone that can't be, it's too large to drag through the ureter there, then it can be lasered, and then those fragments remove themselves. After ureteroscopy, oftentimes a stent is left, and that's just a long hollow tube that sits with one end of the kidney and the bladder to allow the ureter to drain properly. Shockwave lithotripsy is also a major player in this space. A stone that is not likely to pass on its own in the ureter or the kidney can be treated this way. It is an outpatient procedure under some anesthesia. We use X-ray or ultrasound to locate the stone, and then importantly, this procedure is not invasive at all. The shock waves actually come from outside the body, target the stone, and break it up into tiny little pieces. Once the stone has been broken up, then the fragments need to pass on their own. Sometimes, depending on how big the stone is, sometimes this one can take multiple treatments to render a patient totally stone-free. For very large stones or stones that are difficult to see, difficult to localize, either with ureteroscopy or the shockwave, we have the option of percutaneous nephrolithotomy. This is actually a slightly more invasive procedure because it requires a nick in the back, and then we actually pass a scope directly into the kidney, as you can see in this schematic here. The nice thing about this procedure is that it's for large stones. It can render a patient stone-free in many less procedures than either ureteroscopy or shockwave lithotripsy. But again, the trade-off is that it's more invasive. Typically, this does involve an overnight stay, and then hopefully back to work within a week or so. I believe we have a video here for ureteroscopy, just to kind of show how this works. So this is going to be percutaneous nephrolithotomy. So this will just be a video form here. You can see a large kidney stone sitting up in the kidney there. So to begin with, a Foley is placed to drain the bladder. And that's the balloon going up for the Foley there. A scope is then passed up into the ureter itself. So oftentimes PCNL will involve some scoping from below as well. And again, you can see the large kidney stone sitting in here, right here. Contrast has been injected to the kidney from below so that it can be visualized from outside, which will guide the needle placement into the kidney itself. Through a needle, a wire is placed into the tract. This tract will allow dilation to be safely performed to enter the kidney. A sheath is then placed through that tract into the kidney itself. And the sheath allows access of our instruments to actually perform, either direct removal of the stone, or we have we can also laser stones through this tract as well, and then remove them directly. At the end of the procedure, again, we use contrast to make sure there's no injuries to the system. There is a chance of bleeding after this procedure, obviously, because there's direct entrance into the kidney. However, it's usually very well tolerated and safe. A stent is often left at the end of the procedure, as well as a tube directly to drain the kidney. And those are both removed in the postoperative period. And as you can see in this schematic, the patient is now stone-free. So this brings us kind of into a new and exciting portion of the talk. And this is a technology I am very privileged to be able to use for my patients. There is kind of a gray zone between ureteroscopy and percutaneous nephrolithotomy. And that's a stone size probably in the 1.5 to 3 centimeter range, which traditionally is a bit large to tackle with ureteroscopy. But there are some patients who are, for some reason won't be able to undergo the more invasive percutaneous nephrolithotomy, either because of health reasons or just their anatomy. It might not be as good for them. So scopes in this case, you could do multiple procedures, but there's difficulty in clearing stone fragments effectively with that, unless you want to sit there and basket stones over and over again. If you have a very large stone and you can only remove small pieces at a time, you can imagine that it might take a long time on the table for the patient. Lasers can get stone down to dust, but they can't actually remove the fragments themselves. And then again, baskets, if there's many stone fragments or they're very small, the basket won't be able to clear those effectively. So Calixo has come out with this wonderful technology called CVAC or SURE, which stands for steerable ureteroscopic renal extraction. It's essentially a large ureteroscope. And the benefit here is that it can do everything a ureteroscope can, but it also provides better irrigation, better pressure control, and actually better evacuation of small fragments, even up to 2 millimeters in size. Historically, I will tell you that ureteroscopy probably has about a 75% stone-free rate, and that number goes down the larger the stone is. And CVAC is proving to I think probably improve on the number quite a bit. And they're showing some exciting data initially here, and I think as time goes on, it will be, I think they'll compare very promisingly to ureteroscopy. I'll tell you that in my own practice, I think I've saved a lot of patients additional procedures by using this technology. And again, it's probably on par with ureteroscopy in terms of the time spent in the operating room. Typically, I'll spend, about an hour, maybe a little more, depending on the stone size with this instrument. But again, largely comparable to ureteroscopy in terms of side effects and need for time in the operating room. In brief here, and this is very similar to ureteroscopy. You'll have stones in the kidney that you want to go after. There might be some that are large and traditionally too large for ureteroscopy. You do perform laser lithotripsy with the scope, just like you would with the regular scope. However, this one has a aspiration that can be done to pick up all these residual fragments that otherwise would be left behind during traditional ureteroscopy. So at the end, instead of having piles of dust in the kidney, or stones that you can't see because they're covered in dust, instead you have a nice clean kidney with no residual stone. So again, it's an all-in-one system. It is a ureteroscope. You can do lithotripsy through it. It does irrigate, it does aspirate, and then actually collects all your stones for you very nicely here in this little stone collection. So I like this because I don't have to do any basketing, and I can get a good stone specimen, and I can actually visually see how much stone I removed from the patient very easily with this system. It is compatible with most of my laser fibers, and again, the dust removal is actually, I think, helps quite a bit with visualization too during the procedure, and then keeping the patient stone free afterwards. And these are the two kinds of things it does. And I almost wish there was a little video right here I could show you of how well it does this. But it actually, using this irrigation, it kicks the stones up into a slurry and then actively can suck them out as you're lasering. And then you can actually look at the stones and suck them out directly with your scope as well. And again, stones up to 2 millimeters in size, which is not insignificant. I think we have another video to show you here. So the scope is very flexible, and it can access most areas of the kidney without much issue. As in most ureteroscopy, this procedure starts by driving a wire up into the kidney itself, over which the scope can be passed. The scope can be then used to inspect the kidney and find stones. The stones are then lasered and broken down into small fragments. You can see here that dust is being made, which is falling directly into the scope. So actually most of the stone gets sucked up by the scope directly during the procedure. When you're done with that, you might have a small select collection of stones which are too small to be aspirated, too large to be aspirated. So we leave those behind temporarily, but only temporarily. We will come back and get them. Once we've treated all the stones we think are worth treating, we'll actually take out the piece with the laser in it, which allows for active aspiration and larger stone fragments to remove from the kidney. In my hands, I think I've been very impressed by how well this system works. Instead of leaving behind piles of dust, which I hope will pass, I have the benefit of seeing a completely clean kidney and be able to tell a patient definitively that their stones are completely gone. In summary, kidney stones, 10% of the population will get them. If you do have them, I would recommend that you be seen by a urologist to talk about your options for treatment and prevention. I myself do a lot of this work myself in Brownstown and Dearborn, and I would be very happy to have anybody listening tonight as a patient. I do understand that there are a large number of questions from the audience. Are bladder stones just as dangerous as kidney stones? And the answer is potentially. It's kind of a different ballgame because the bladder tends to, if you have a stone in your bladder, it doesn't tend to obstruct. However, it can cause infection, it can cause pain, it can cause bleeding, and it's often associated with bladder obstruction itself, which can be quite dangerous. I think if you have a bladder stone, it's certainly worth seeing a urologist and talking about treatment options. Protein drinks, because it's a high amount of animal protein, if you are a uric acid stone former, it could end up being a negative for you if it makes you form more stones. So again, less than 6 ounces of animal protein is the goal. I guess if you had a soy-based protein shake, maybe that would be less dangerous in terms of stone formation risk. She had a stone this year that passed on its own. Unfortunately, as it's passed, if you don't actually have the stone in hand, it can't be sent for analysis. That being said, there is a metabolic workup that can be done to see at which stones you're at risk for forming. And based on that, hopefully prevent you from forming more stones. I will say that having a stone to analyze is helpful in figuring out what your specific risk factors are and what can be done to prevent more. Someone with chronic kidney stones, more than 3 a year, calcium oxalate stones, low oxalate diet, plenty of water, 3 millimeter stones get lodged and an infection forms every time. So unfortunately, for a patient like this, someone with a lot of kidney stones, it can be very frustrating, even if you're doing all the right things. It seems like here there's probably a metabolic cause or maybe even a genetic cause at play. I'm assuming this person is already in contact with the urologist, but may benefit from additional metabolic testing to see if there's anything more that can be done to kind of adjust that stone risk down. And the other thing I would say is, if someone like this has, stones, prophylactic treatment of stones, if they drop and cause a problem, particularly if you're getting septic over and over again, would probably be a good idea. So instead of waiting for the stone to drop, trying to go up and actively clear out the kidney before the stones become an issue. Do stones have to be a certain size? It depends on where they are. If a ureteral stone or a stone that's causing obstruction, it could be 3 millimeters or less and still cause issues. Often at that size they do pass on their own. Obviously, if it's stuck in the ureter or if it's a large stone, particularly greater than 7 millimeters in the kidney, those become worth treating. Enlarged prostate can make stone removal more difficult. It gets in the way of instrumenting the ureter sometimes, and also can cause bleeding during the procedure itself. However, that being said, I've treated a lot of men for kidney stones who have enlarged prostates without issue. So I would say it's occasionally an issue. Because 8 millimeter stone can't be seen on an X-ray, but can be seen on an ultrasound. Well, that's probably a uric acid stone because those are often can't be seen on X-ray, but can be seen on ultrasound. I would talk to your urologist. Again, uric acid stones are the kind that often can be dissolved just by actually alkalizing the urine. Drink more water, have more citrus. And again, talk to your urologist about your specific. She has MS, gets lots of urinary bladder infections, but is eating lots of Spanish almond stones in the kidney. How do you know if infection caused the stone or high oxalate? And it can be difficult to tell. Sometimes there are clues on the X-ray based on how dense a stone is, or if you're getting the same infection over and over again with the same kind of bacteria, particularly a stone-forming bacteria, that would raise my suspicion that that was a infection stone. But unfortunately, just by looking at the films, you can't always tell. Are bananas bad for stones? Not really. Not a high-risk food. I will tell you they're not particularly good for stones either. Again, the citrus fruits are the best to prevent stones. Last spring, he had bloody urine, went to the ER, was diagnosed with a stone, given a funnel with the screen to catch the stone, but the next day the urine was clear. After 4 days of screening, never had stone, never had any pain. So the best thing to do here, the fact that the pain is gone, is a good indication that the stone is probably gone as well. You don't always see them pass. However, if you don't actually see it pass, there's a concern. This is probably a low risk, but there is a concern that the stone might be stuck in the ureter and maybe partially obstructing the ureter, but not causing enough obstruction to cause pain. So in general, I would recommend that patients who had a stone confirmed on imaging, but never saw it pass, probably have follow-up imaging at some point in the next month or two, just to make sure that there's no residual obstruction or other stones in the system with treating. How are you able to visualize the field as you work? Well, the nice thing is our scopes are actually fiber optic. So you can see here we have a light source on either side, and we have a camera port right here. So the stones, the modern day scopes are usually digital, but we can see the whole field as we work. And actually, modern day optics are pretty incredible compared to what we used to be working with. So we can generally see what we're treating, which is nice. How much water do I recommend? For stone former, the goal is at least 2 liters of water a day, and sometimes up to 3 if that's not enough to prevent further stones. Taking Tums for heartburn lead to kidney stones. Yeah. So again, the goal for calcium in a given day is probably up to 1,000 milligrams. If you're taking Tums, you can easily surpass that, particularly if you're taking 2 a few times a day. They could easily get over that. It's usually not an issue because most folks don't pop Tums like that. But if you did, and you're that could be a risk factor for stone formation. Are raisins and craisins bad for stone formation? No, they don't really affect stone formation. Is there such a thing as too much lithotripsy, and what is medullary sponge kidney? Medullary sponge kidney is just a metabolic condition where the kidneys tend to produce and calcify too much calcium and become calcified. Is there too much such thing as too much lithotripsy? Unfortunately, yes. It's kind of a risk factor for a chronic stone former who's forming so many stones. The more procedures and the more stones you have, the higher risk you have for things like strictures or scars in the tract, which can cause problems draining the kidneys. So our goal in general is to treat the stones you have, but then prevent you from having more if it's possible. Now, there are some folks who have very difficult to prevent stones, and so I would recommend that they follow closely with the urologist to kind of prevent that as much as possible. In terms of prevention, what's the best way to protect your kidneys? Drink 2 liters of water a day at least. Good hydration. Get your citrus. Control your salt. Control diabetes and blood pressure if those are present. 24-hour urines are excellent in this space for kind of figuring out what your specific risk factors for stones are. That's where you pee into a jug for 24 hours. We send it off to a lab, and we get a nice readout on what your specific stone risk factors are in terms of things that you put too much into your urine, like calcium, oxalate, sodium, or things that you could be adding to your urine that you're not. Like if your pH is too low, well, you can increase your pH by use of medication or citrus fruit, and oftentimes that will prevent further stones. I have a stone which was collected and passed last fall. Can it still be analyzed? Yes. Because it's a mineral, the composition does not change. Can collagen peptides contribute to stones? Yes, if you were taking a lot of them. Is the CVAC procedure covered by Medicare insurance? Yes, it is. It's actually covered by pretty much all major Medicare, Medicaid, and the commercial insurances as well. The recovery times for the procedure, as I discussed. So for ureteroscopy, recovery time is usually in the order of 2 or 3 days. SWL is probably similar. PCNL, again, it's an overnight stay in the hospital, and then usually about a week till you're kind of, I think, back to normal. Extra metabolic testing, is my office able to do those tests? Yes. And then in terms of being proactive about removing from the stones from the kidney, Yeah, I think, and again, it's kind of up to the individual patient and the urologist about which stones are worth treating. In general, my philosophy is if a stone is too big to pass, or if it's going to cause a lot of issues passing, and again, my rough benchmark is about 6 or 7 millimeters for most patients, then that's probably a stone worth at least considering going up to get before it does drop and cause a problem. Most patients would prefer to be able to schedule a procedure on their time as opposed to ending up in the emergency department with a stone that might drop at an inconvenient time. And yes, my office does do the metabolic testing, and I'd be happy to discuss anybody's individual case with them. If a urine has excess bubbles, is this indication of a possible stone? No, that's not a stone symptom per se. So it looks like this is a question on what the sepsis risk is with large stones, particularly with percutaneous nephrolithotomy. Unfortunately, infection is a risk anytime you're instrumenting the kidney. The kidney itself is pretty sensitive to bacteria, and bacteria can certainly be present in the urine and in stones themselves. So it's not a large percentage of my patients or patients in general who have issues with infection immediately after a procedure, but it can be an issue, and it can lead to additional hospitalization time. It can be prevented, particularly with testing of the urine before the procedure to see if there's active infection present. And oftentimes we can also give antibiotics for a short time before and after a procedure if there is a concern that infection is going to be an issue. The question here is for catheters for shockwave lithotripsy, and I'm assuming this refers to a Foley catheter. That would be up to the individual urologist. I actually personally don't do a lot of shockwave lithotripsy yourself, so I don't have a strong opinion on it personally. I'm going to wait for a few more moments here just to let any additional questions come in. But thank you very much for listening, everyone. It's been a pleasure to speak with you about this important topic tonight. And again, further questions, I'd advise you to talk to your urologist. And if you're looking for a urologist, I'm very happy to see you myself. Here's another question. Is it best to urinate during the night to prevent stones? In general, most of my patients don't like getting up at night to urinate. So if you can hold your urine all the night, congratulations. And if you do that, you're not at additional risk of forming a stone. That being said, it's not gonna change your risk if you are or not getting up at night. I don't want you to feel like, my fluid recommendation means you have to drink night and day. If you can get your fluid all in the daytime hours, that's preferable, and particularly before dinner. And they'll probably let you do most of your urinating during the day and give you a break during the night. All right, folks. Well, have a pleasant evening, and I wish you all the best, and particularly for the stone formers out there, best of luck in your further in forming no more stones. Take care.